So I think what this shows, one of the main important things, is the increasing value of real-world data and data sets. So this was done by looking at publicly available data sets on request, patients, and looking at data from that. And I think that's very underutilised, and we could be making more of it. So a lot of this was to show that that's available and is useful to answer some of our questions. And it showed a trend towards improved survival when you give cabozantinib second line compared to axitinib, but I think the other part was really to show how useful and available now real-world data is, and we should be using this more to sort of answer routine questions in a population. So I think we still don't know optimally the scheduling of which agents to give when. So if we've given TKI plus IO first line, you know, at the moment we're still giving TKI second line. Do we need newer therapies? Do we need to be biopsying these patients and making a biological choice? I think the other thing is, obviously STAR was on intermittent therapies, but with the newer combinations with immunotherapy, should we be giving that in a similar sort of way for a period of time, stopping and restarting? And also for the IO-TKI combinations, I think those are important questions. One of the questions that often doesn't come up at meetings, though, I think, is what to do with the poorer performance status patients, because unfortunately most of these agents are PS 0 and 1 patients. And it would be great to have the equivalent of an endocrine therapy for breast cancer that you could give to older, frailer patients. So I think there's still very much an unmet need in that group as well to have a very tolerated treatment, targeted treatment that they could take and still have comorbidities and BPS too, because I think that's a group we still can't really treat as we would like to at the moment, and many of them are on best supportive care. So today I've obviously been to the presidential symposium, so we've been hearing from the two groups, Professor Pazazzi's group and also from the STAMPEDE presenters, Professor Attard, about the updated data with abiraterone. And that's particularly exciting, showing that you should be really using that agent in all hormone-sensitive metastatic patients and the improvements in survival. And I think that, you know, I can't see that becoming part of standard of care very soon. It's interesting also from the point of view that the scale of what that will mean in terms of the need to implement it for additional oncologists. So while it's welcome news, it will need quite a lot of logistics to do that. And I think the other message was that, you know, these are great improvements, but we need to also look maybe at the longer time toxicities from some of the drugs in a group that may have many years of survival. And although there appeared to be no obvious signals that things were worse with the combination, we need to just keep that in mind for things like cardiac disease, diabetes, other factors. So I think that was exciting data, 2 trials really reinforcing the role of combination, one with abiraterone and ADT, the other with combination with chemotherapy. And they're likely to be practice changing, and it's exciting, but it's really how to implement that in a very common cancer. So I think obviously combination therapy in the metastatic setting, and obviously there's quite a lot of interest with immunotherapy in the intermediate and high risk adjuvant setting. And obviously if that becomes standard of care, that would be real treatment changing, because at the moment most of us don't standardly give adjuvant treatment. We simply follow, you know, scanning and routine follow-up, and if patients become symptomatic. So that would be practice changing, and for a medical oncologist it would add an additional arm of treatment, and also then ask questions if you had that in the adjuvant setting and you progress, what would be your next line of treatment. But it's exciting to think, because I've been 16 years as a consultant in renal, and in that time none of the adjuvant treatments have really been adopted. That we can see that that might happen. It might not be for all patients, but it's certainly on the horizon, which is, you know, kind of very promising, I think. In COVID, things have been slightly different, and we've been allowed treatment breaks before the results of my trial came along. But obviously, normally with treatment breaks, we're constrained to a 6-week treatment break for toxicity reasons. So there's constraints of what you can give and how you can actually give it. I think the other thing is often in trials, having the fitter patients in some of the immunotherapy trials, and I think the older age group of the STAR slightly reflected the real world population. You know, in my practice, I have a lot of others with comorbidities. I work in areas where there's been coal mining and other heavy steel industries, and the performance status of those particular patients might not be high enough to give either combination treatment. So I think it's continuing to advance in the agents we give, but realising we still have to individualise for an individual patient and their particular comorbidities and frailty and all those kind of things.